Hi, good afternoon. My question, I have actually two questions. My first question, I already asked Dr. Beck of a while ago in another meeting, is unless you address the AC joint arthroscopically, like Dr. Martin, do you think there's still a role for arthroscopy in AC joint stabilization? What do you really do arthroscopically that you cannot do openly? And my second question is a little bit off the team, but it's also related to AC joint. Do you address AC joint arthritis when you do reverse? Do you treat it? Do you think it's important for the recovery of the patient? Thank you.
So,
I can try to answer the first one. As I do the reconstructions open, I never do the arthroscopy. I may be a little bit naive. I know there are many studies showing that you have associated injury, especially in high grade, like grade 5. But I also think that some of these studies show slap tears and other things that may not be real pathology. So I don't see it in the results. I don't see patients coming back 4 months after the reconstruction say, I still have shoulder pain another place than the AC joint. So I don't believe so much in that. I think there's a risk of overdiagnosis if you do the arthroscopy. Of course, you should be aware from the MRI if you have a cuff tear or something like that. But many lesions are asymptomatic, I think.
I agree with Klaus. If this is a question about the additional injuries, in my experience, is under 10% of the additional injuries you can have, like labrum lesions or rotator cuff tear. Of course, they're difficult to diagnose before. So in my experience, those high numbers of the additional lesions are probably pre-existing injuries which are not clinically relevant. In fact, I ask all the patients, did they have the problem with the shoulder even before?
I'll comment on both your questions. So I never scope when I do the AC joint stabilization. It's two different pathologies. If they have problems with the inside of the joint, it will be treated in a different stage. If this is an injury to the AC joint, I deal with that open. Now, on the second question, whether I do anything for the AC joint when I do a reverse, I always do it for reverse and anatomic. I use the anterolateral approach in Navas and Mackenzie. I always take out the AC joint in all joint replacements that I do regularly.
So Frank, what do you do in reverse, the AC joint?
It's interesting to hear that Dr. Arealis does it all the time. I never do it.
I thought so.
I never do it. I never touch the AC joint. Yes, but you could do it. You could also do it, of course. I don't do it just because I can do it. I don't do it because you don't need to do it. This is my opinion.
Thank you. Questions, comments? Anton.
Ladislav, may a question for you. You showed a picture where there's some, you call it osteolysis after a conservative treatment. So there was no surgery. We showed a picture where you said there's some osteolysis because there was some widening from the AC joint. You really think it's osteolysis, or what do you think would be the reason? The reason I asked the question is that we're just getting out our own long-time results of a full arthroscopic stabilization, with a mean follow-up of 5 years. And the only thing that we found after 5 years is in 22% of the cases, widening of the joint. There's no vertical displacement, it's just widening. So why, do you have an explanation why you call it osteolysis? Is it really osteolysis, or is it just laxity, or grade 2, as we call it?
No, in this particular case, it was not just a widening of the AC joint, but actually, if you watch correctly, it is the shape of the distal clavicle was changed. So it was vertical at the beginning, and then it was a part of the, like a groove on the below of the clavicle. So, and this patient even has a pain in the first few weeks. And I think that this is the cause of the irritation, or just rubbing of the bones together. It is like a reaction to the bone because of this pressure. But this is just occasional observation, and I have no scientific data about this.
What happens if you overload the AC joint? It's like the weight. Your repair is really good and strong. You overload the distal clavicle, and then you get. It's similar to weightlifters. So the weightlifters get pain on absorption of the bone on the distal clavicle, osteolysis, because the lower joint is overloaded. If you do a very strong repair, and it's a very rigid repair, then the distal clavicle is overloaded, it absorbs to allow for ongoing movement. That's what. So if you have a perfect repair in a way, if you overcorrect a little bit, then you might get this distal clavicle absorption.
Andreas. There's a comment over there.
Please.
I want to ask a question.
Yes, they have a question. Okay.
My question-
Please
Excuse me.
help me,
Yeah.
Grigory. Hello?
I see you.
Just a comment for that. I don't believe that is an issue. Andy Forst did biomechanics. We looked at the pressure inside the joint, and you cannot compare that to a weightlifter. The weightlifter is biomechanically, then you have the pressure inside the joint. When we do the reconstructions, because the AC joint is not like the knee joint, then you don't have increased pressures. And we've also seen that when we do a slight overcorrection, about the 3 millimeters, which is normal, we have never seen, or in our long-term results, we have not seen osteoarthritis being a problem or an issue with the AC joint. And even Markus Scheibel has shown in AGSM this year that when you go with a slight over-reduction, you have better results in the end of the day. So I think that's not an issue that we have an osteoarthritis problem there.
Thank you, Lado. There are some questions from the floor.
I have a question in the panel. How do you deal with a patient who has a type 3 AC joint dislocation with horizontal instability and a fracture of the base of the coracoid?
That's a very good question and very difficult to handle. Basically, you tend to do you have to know why is it a grade 3. Is it because your coracoid got displaced and the ligaments are still intact? Or is it a grade 3 because the ligaments are really torn, but usually the forces already go through the coracoid. So usually you're fine when you fix the coracoid base. I don't know how you see it, but this is my opinion on this. Yeah, so you fix the base of the coracoid and always you address the AC joint, and you see also if the disc is intact. The AC joint, usually it's just stripped off, like in a normal grade 3 or grade 4, 5. You just put it back onto the. Yeah. So no extra sutures, just some sutures to fix the AC joint capsule to where it got stripped off. Usually it's from the clavicle.
Any more comments?
I have a question for Dr. Kovasis from. This is related to his presentation on arthroscopic AC joint reconstruction. So I just wanted to know what is your level of calling AC joint dislocation as chronic, and what stage in chronic AC joint reconstruction you like to excise the disc in between, because it is wonderfully demonstrated by the last speaker, the aerialist, about the AC joint resection, and at what level you will intervene for the AC joint resection for arthroscopic AC joint reconstruction.
I share the same opinion like Frank or the others, so I'm not in favor of the AC joint resection or distal clavicle resection. I think that we have to maintain the whole length of the clavicle, and for me this is important. And in chronic cases, it is for me really rarely to see problem with the disc. Usually it's already some kind of changed, and there are some chronic changes. So maybe sometimes it's difficult to, if you have a fixed dislocation of the clavicle, then you have to clean the AC joint. Otherwise, it's not really necessary.
Those
I'm speaking for a grade 3, 4, or 5. For a grade 3 in chronic cases, I think it's the same. If I can just comment the question about the coracoid fracture and type 3. Maybe type 3 we can leave, I don't know, but in type 4 or 5, where if you have a gross malposition of the clavicle, this is for me an excellent indication for some other technique to the AC stabilization, like a hook plate or something like this.
Just one comment back to the corner over there. Over the last years, I did not have to go back in and resect the AC joint after stabilizing it without resection. And if AC joint osteoarthritis would occur, I would rather go in later and do a bipolar resection, not harming instability. But I think the risk that you have to go in back later is very, very small.
Just a short comment. I think there are studies showing that 88% of all you here have AC arthritis on X-ray. So watch out if you meet an orthopedic surgeon.
question?
What do you do to the disc in the acute AC joint dislocation? Do you excise the disc or you just preserve it?
The disc.
Yeah.
I don't do a disc resection. I open it up, of course, the joint in the meantime. In former years, I did not, but now I do it. If it's completely torn, if it's like inside the joint and the reduction can't be performed as long as it's there, I take it out. But if it's intact, I don't touch it.
Yanis?
As I mentioned to my presentation, I don't resect the discoid meniscus, and I have the same results with all the patients. No functional problems, no pain, residual pain.
Any more questions? Yes, please.
You all get very, very light questions. Now you have, if you have chronic stability, let's say grade 2 to 3, also grade 2 can be very painful. Osteoarthritis developed already, and painful scapular dyskinesia. What to do? I have such patient now, and I don't know what to do exactly.
Yes. If someone has scapular dyskinesia, unless you correct that, whatever you do will fail. So you need to start with.
Now I sent him now to physiotherapy.
Yes,
of course.
that's what you have to do.
For the beginning.
Yeah, you inject, you start working on the scapula, and then if it's arthritic, you can try a resection and see whether that solves the problem. If that doesn't, then you might need to stabilize it.
Also there is small
Cysts.
instability in horizontal and up to down.
Then you can do arthroscopic resection and then stabilize it if it's obviously unstable while you operate. But start with physio, correct the scapula. Without the scapula, nothing works.
Yeah, Claudio, quickly, can you make your comment also on this topic?
Yeah, so if you, first of all, of course, I would do an injection and physiotherapy because scapular dyskinesia, you don't know if it is from the instability or from the pain. It might also come from pain, the scapular dyskinesia. So if you inject, usually it should be fine for at least 3 to 6 months. In this time, the patient will have time to correct his scapular dyskinesia, and then, yeah.
So the problem is solved.
Okay, so still in scapular dyskinesia, But well, what I would do, I would inject it myself, because in the AC joint, I don't have limits. I had the AC joint resection myself. I had 5 injections before. It didn't have for a long time, but it's, you can, in my opinion, in the AC joint, you can inject more or less ad libitum if you're really inside. Yeah, and then I would repeat it myself. I do it ultrasound guided, but it's not needed. If you know how the anatomy, you can find the AC joint. And then I would myself, like do a physiotherapy program with the patient, see him back at 3 months, and then I would either go, if he's still, let's say, scapular dyskinesia and AC joint, I would resect the AC joint and see what remains of the instability and the pain and of scapular. So it's a stepwise approach in my opinion.
Thank you.
What is your opinion?
We're about to close.
I think it's a very.
Go ahead.
I think it's a very hard question, and I'm happy we don't see this patient very often. But of course, you have to figure out what is his main problem. Is it osteoarthritis or is it instability? In this case, it seems to be both, and you can't figure it out. Maybe the same approach as I said before: stabilize it, let it go, and if it's still a problem, go back in and do a bipolar resection. This is what we know from literature as well. Do your resection bipolar, and you won't have any instability problem.
Thank you very much. Is there any specific question from the floor? We will conclude the session. There's a missing talk by Giancanni, so in order to make up for that, thank you very much. Thank you.